and participants in our RISACON DNBA academic activities online session. Today we have an interesting session on clinical case presentation with chronic kidney disease patient, and it's a very interesting case. Professor Nagaswamy sir has given the case scenario, and I now invite Dr. Pavitra, from third year student from Annamalai University Medical College, MD, for presenting the case. Over to Dr. Pavitra.
Thank you, sir. Good evening, sir.
Good evening.
Shall I start, sir?
Yeah, please go ahead.
Challaman, 45 years old female, coming from Kanchipuram, who is coolie by occupation, coming with chief complaints of decreased urine output for past 2 years and swelling of legs and facial puffiness for past 2 years. History of presenting illness. Patient was apparently normal before 2 years, after which she had reduced urine output for past 2 years. Initially, she was passing 1 liter per day of urine output and progressively reduced to 500 ml per day. History of passing high colored urine, no history of hematuria, dysuria, pyuria, no history of burning micturition, no history of urgency, frequency, and difficulty in micturition, no history of pain during micturition. History of pedal edema for past 2 years, insidious in onset, slowly progressive, symmetrical. Initially, it was around ankle, now increasing up to knee, aggravated by sitting posture with legs flexed, relieved by rest, associated with facial puffiness, more on morning time when she wakes up and decreases as the day progresses. History of loss of appetite present, no history of loss of weight, no history of regurgitation of food, vomiting or peptic ulcer disease, no history of melena, bleeding per rectum, history of easy fatigability present, no history of any bleeding manifestation, no history of dyspnea on exertion, no history of chest pain, palpitations, syncopal attacks, no history of orthopnea or PND, no history of fever, chills, rigor and abdominal pain, no history of insomnia, no history of altered mental status, tremors or drowsiness, no history of convulsions, memory loss and altered sensorium, no history of generalized pruritus or easy bruisability, no history of muscle cramps, numbness or tingling sensation. Past history, she is a known case of type 2 diabetes mellitus for past 10 years and now on treatment with insulin, and known case of hypertension for past 5 years on treatment. She was diagnosed to have Ckd on evaluation for frothy urine, swelling of legs and decreased micturition 2 years back, and was started on oral medication. Then hemodialysis was initiated through AV fistula in the left forearm electively. Now done 3 times a week. No history of decreased BP, breathing difficulty, itching, muscle cramps during dialysis. Last dialysis was done 2 days back. No history suggestive of TB, bronchial asthma, ischemic heart disease, seizures, allergy. No history of chronic analgesic intake. No history of previous surgeries. No history of previous blood transfusion. No history of any addictions. Family history. No history of similar illness in family members. Personal history. Patient is on mixed diet, decreased appetite, bladder and bowel habits normal. Sleep normal. General examination. On examination, patient conscious, comfortable, moderately built and moderately nourished, afebrile, pallor present, bilateral pedal edema present up to leg, no icterus, cyanosis, clubbing, lymphadenopathy, no external scratch markers, an AV fistula on the left forearm present, height 150 centimeter, weight 40 kgs, BMI 17.7. Airway examination. No apparent facial anomalies, facial puffiness present, mouth opening 4 centimeter, Mallampati class 2, temporomandibular joint mobile, temporomandibular distance more than 6 centimeter, neck movements normal, no loose tooth or artificial dentures. Vital signs, pulse rate 96 per minute, regular rhythm, normal in volume and character, peripheral pulses felt normal, AV fistula present in left forearm with thrill present, BP 140/100 mmHg in sitting position in right upper limb and 130/80 mmHg in standing in right upper limb. Respiratory rate 15 per minute regular. Temperature 37.2 degrees Celsius. SpO2 99%. Abdomen on inspection flat, all quadrants moves with respiration, no visible scar, sinus, dilated veins or pulsation. Renal angle free, umbilicus is in midline. Palpation, soft, no organomegaly, hernial orifices normal. Percussion, normal resonance sound heard over abdomen. CVS, cardiovascular system, JVP not elevated, apex beat felt on fifth left intercostal space mid clavicular line. S1 and S2 normal, no murmur. Respiratory system, bilateral normal vesicular breath sounds here, no added sound. Central nervous system, no focal neurological deficit, higher mental functions normal. Summary, 45-year-old female, known case of diabetes, hypertension with history of CKD stage 5 on hemodialysis thrice weekly for past 2 years, now presented with decreased history of urine, swelling of leg and facial puffiness. On examination, patient is conscious, oriented, paler, bilateral pedal edema with loss of appetite, awaiting for renal transplantation. Thank you, sir.
Okay. But the case scenario that was given is slightly, I think it's a little variant from what you are now presenting. Isn't it? Did you get that case scenario correctly? There was no mention of any name or anything. I'm very good. You have made it look realistic by adding the name of the patient and all that. But the age is same. It was mentioned in the case scenario given by me is a 45-year-old patient with history of 10 years of diabetes mellitus and 5 years of hypertension, diagnosed to have CKD on thrice weekly hemodialysis, posted for bilateral nephrectomy, waiting for cadaver donor or deceased donor transplantation after an interval. That is the case scenario that was given.
Okay,
Did you get that full case scenario, or you got only like this?
No, sir, I got that case only, sir.
Whatever you have described. There was no mention about nephrectomy in the
Yes,
case
sir.
scenario.
Yes, sir, I have received, sir, bilateral nephrectomy, needs bilateral.
Then that so it is not going to be a straight transplant, and it is not going to be a live donor transplant. Two things that are mentioned are it is a patient with CKD on renal replacement therapy. Now requires a bilateral nephrectomy first, followed by a deceased donor transplantation, probably because she does not have a related or unrelated live donor for her to undergo a transplant. Okay, so this is a slightly variant case scenario than the normal case scenario that are given in the examination. Okay, mostly they will keep. The reason why I gave is last year I have discussed CKD coming for transplant, where I have mentioned the various scenarios at which patients may present to us as a challenge. Okay, before transplant, when they are on dialysis, without dialysis, or after transplant, all these scenarios I have mentioned in that discussion. So I thought I will just give a little bit of variation to avoid boredom. Okay, instead of repeating whatever has been said, I thought I will stimulate a little bit of thinking and then try to induce some enthusiasm into the candidates preparing for presentation. Okay. Now, a few things I think you have missed in your history. Whenever there is a history of 10 years of diabetes, what are all the other questions you should have asked this patient? The problem first started was only diabetes for her, isn't it? Not straight away CKD. Okay. So what are the other questions when you get any diabetic patient, for example, not only for renal transplant or other surgeries, what are the common questions you should ask a patient when they say they have a history of long-standing diabetes?
The history of joint pain.
History of joint pain for diabetes? See, the first pathology that happened in this patient is diabetes mellitus, which is the notorious cause for the CKD, isn't it? And majority of the diabetic patients are prone or likely to develop CKD if they don't control their diabetes properly, isn't it?
Yes, sir.
So how do you elicit a history? Why she should have gone on to CKD with only 10 years of diabetes? What are the reasons? So what questions you should have asked the patient?
Sir, history is related to autonomic neuropathy, sir.
Okay. So unless you understand how diabetes causes the CKD or the diabetic nephropathy, what is the pathophysiology, then you will not be able to ask those questions, isn't it? First of all, whenever a patient says they were diagnosed with diabetes, you should ask how it was detected. Why that question is important? Any diabetic patient coming to us for preoperative evaluation, if they say they have a long history of diabetes mellitus, what is the importance of asking a question, how your diabetes was detected? Isn't it?
Sir, any family histories?
Very good. Okay. It may be running in the family. Okay. So does that mean that my wife, usually how will the patient say, I had this problem, so I went for this. Otherwise, I was frequently urinating in the night, or I was feeling very thirsty. So I went and consulted my family doctor. Then he asked me to get a blood sugar done. It was very high. Then he diagnosed. That is one category of patients, isn't it? Classical polydipsia, polyphagia, polyuria. But nowadays, that sort of presentation is not at all common. Even the specialists who run so many diabetic clinics, they say because of the variation, the nature of living, the stress in the life, all those old descriptions of polydipsia, polyuria, polyphagia have not presenting in a classical way in many patients, isn't it?
Yes.
Okay, so majority of the cases are diagnosed when they go for a master health checkup or an incidental wound which is not healing, okay, or a recurrent UTI in a patient who is a female. Okay, all those things will make the doctor suspect that she may be harboring. The beauty of diabetes is, or the classic nature of diabetes is, that many patients do not know that they are diabetic for a long time until it is discovered. So what examination or what test will show that they are diabetic for a long time? Even though blood sugar is randomly done once and it comes as say 210, which test will tell you that they have been a diabetic for quite some time?
Sir, HbA1c.
That is a very important test. So if you do a HbA1c and it shows 7.2, 7.5, that means they have been harboring it for quite some number of years or months, isn't it? Even though it is valid for 3 months only, the HbA1c is very important test to identify whether it has been there for quite some time. On the contrary, if it is less than 6, you can always say they have contracted this only recently. Okay, so that is the first and foremost question that you should ask. Okay, and when
Yes, sir.
the what is the second question you will be asking when a patient says, I am a diabetic?
Sir, any other associated comorbidity?
Associated comorbidities, will you ask the patient?
Sir, like
No, with
hypertension.
regard to hypertension, it is already there. 5 years of hypertension history is there.
Okay, sir.
With regard to diabetes, what else you should ask? Was she started straight away on anti-diabetic drugs like either oral, or was she first advised lifestyle modification, wait for some time and then go for any or medication? That history, don't you think is important?
Yes, sir.
And what will it tell you? Supposing she says, my doctor said you are a little overweight, you reduce weight, you go for walk every day, you cut down on your carbohydrate intake, you modify your diet. We will wait for 3 months, 4 months and see. Then we will think whether you need any medication or not. If that is the history, what is the importance? Or straight away, if they start her on, say, metformin or sulfonylurea and ask her to start taking it, what is the importance?
Sir, lifestyle modification have to be.
No, ma, please understand my question. See, one patient says, my doctor did not start me on medication straight away. They said, you go for lifestyle modification and diet alteration. We will wait for 3 months. That is the history you receive from one patient. Let us take another patient who says, my doctor immediately prescribed me tablets and I started taking it. What is the difference between these two? Who is correct in treating this patient? Which doctor or which practitioner is correct in treating this patient? Supposing you get a patient tomorrow, your own relative comes to you with some complaint, you check for blood sugar, HbA1c is say let us say 6.5 and random blood sugar is 200. What will you do? See, always develop the habit of thinking on the lines of a general physician first, okay? Because anesthesiology is such a beautiful specialty that you are primarily a physician helping the surgeon. Okay, so always learn to be acting as a physician with a good base of medical knowledge so that you can treat the patient correctly even if somebody makes a mistake and sends them for assessment. It is not our job to just give anesthesia and get away. We should learn the medical problems thoroughly so that even if somebody else makes a mistake, we can correct and give a good result to the patient. Isn't it? So, if the patient has been advised only lifestyle modification, the diabetic status is not very severe, isn't it? The blood sugar is not very high, HbA1c is not very high. Then what you say is you go for lifestyle modification and wait. Don't start on the medications. On the contrary, the HbA1c is very high and the blood sugar is also very high and patient has classical symptoms. Then you have to start them on medication so that you can get the control as early as possible. Okay.
Okay.
Is there, what are all the clinical features which indicate that a diabetic patient is likely to become a CKD patient? Are there a few indicators? Supposing somebody says, I am a diabetic for 5 years, they are not a CKD patient. Okay. They say I have been a diabetic patient for 5 years and they are coming to you for the first time. How will you evaluate them from the clinical findings that they are likely or potential candidate to go in for CKD?
Sir, numbness.
Numbness where?
Sir, glove and
That is peripheral neuropathy. Is it an indicator of possible CKD?
Puffiness over the face during your
Puffiness means that already CKD is established. Now, as of now, she is having a normal urine output. She is not having any features of uremia. She is a diabetic for 5 years. She wants to know, doctor, I searched in the Google and said diabetes can produce kidney disease. I am worried. So can you tell me whether I am a potential candidate for kidney disease or not? If this is the question I am asking you as a patient, what will be your answer? Or what are all the complications that happen secondary to diabetes, which can give an indication that this patient is a potential candidate for chronic kidney disease?
So diabetic ketoacidosis.
Ketoacidosis, is it an indication of CKD?
Diabetic retinopathy, sir.
Diabetic retinopathy, excellent. One condition, very good. Anything else? Hypertension. See, patient who has not been an hypertensive, if they start developing hypertension after developing diabetes, that is the first and foremost possibility that they can go in for CKD. Second is retinopathy. Third is microalbuminemia. Okay. So these are the three things which you have to suspect and tell the patient, look here, you are likely to become a CKD patient or like get a diabetic nephropathy. Hypertension in a previously non-hypertensive patient, retinopathy, microalbuminuria, all these three things are potential indicators for future nephropathy. Okay, so what are the methods to prevent a nephropathy occurring if these three things are present? Supposing after 5 years of diabetes, a patient comes to you not for anesthesia purpose. As a family physician or a friend, they come and consult you tomorrow after you graduate and go out. They say, they want to ask you, madam, I went to another doctor. He said, you are developing BP, you have got some visual disturbance, and your urine shows some albumin. So you should be very careful. You are likely to go for kidney failure. What should I do? If they come and ask for advice like this to you as a family friend, what will you advise them?
Adequate blood sugar control.
Yeah, very good. Glycemic control, number one. Is that enough?
Anti-hypertensive, sir.
Hypertension control. Yes, these are the two things. So you should tell the patient that you should keep your blood sugar well under control and your blood pressure under good control. If you do these two things, you can avoid or postpone the renal damage for a number of years. Okay. So you never asked about the patient's drug intake, isn't it?
Yes.
Your patient has been on diabetes for 10 years and she has been on hypertension for 5 years. And in your history taking, you have forgotten to ask about the medications that she has been taking. Why it is very important to ask about, especially the diabetic medications in a patient with DM developing CKD? What will happen to the drug requirement? Will it go up or will it come down if a patient develops?
Sir, low reduction in dosage.
They will require lesser dosage of drugs. Why?
Sir, the insulin sensitizers will be less in CKD patients, sir.
Insulin sensitizers, if they're less, you require more insulin, isn't it? Supposing body has, insulin resistance or sensitizers decreasing happens in obesity. That is why patients become diabetic. So is that the mechanism of the lower requirement? If the sensitivity decreases, they allow
decreased metabolization of the drugs, sir. Clearance of the drugs will be very slow in CKD patients.
So that is the reason why it is required. It is not the reason. See, insulin is after all metabolized and excreted by the kidney. When the kidney starts failing, the metabolism of insulin and excretion of insulin gets decreased. So there is more insulin available compared to a patient without CKD. So automatically patient is likely to go in for hypo feelings if you continue with the same dosage of medication. In fact, patients who were on insulin earlier, when they develop full-fledged ESRD or stage 5 CKD, their insulin requirements will come down drastically. Unless you moderate that, they are likely to go in for severe hypoglycemia attacks. Hypoglycemic attacks are very common. Okay. So that is the reason why you should ask about the drug history. And what about the anti-hypertensive medications? What should be the ideal antihypertensive prescribed if a patient develops hypertension after developing DM?
AC inhibitors.
AC inhibitors or
ARBs.
ARBs also. Why they are the preferred drugs? Why they say AC inhibitors or ARBs are the ideal drugs for a patient who develops hypertension secondary to diabetes mellitus?
It decreases the
sodium and water retentions.
Yeah, it decreases albumin excretion. It decreases deterioration of renal function because it acts on so many ways. Angiotensin 2 is important. I'm going to show you the pathophysiology of DM causing CKD. Then you will understand all these points. Okay. So you should ask for that. And when you ask for the history of medication for diabetes, first you should ask how many drugs were started, were they started on multiple drugs or single drug, and what was the control, how often she got herself tested, what is home glucose management or monitoring, HGM.
Sir, monitoring using glucometer.
Yeah. So that is a very important thing which nowadays most patients do. That is called home glucose monitoring, HGM. Okay. So by doing that, they know whether they are having a good control or whether they are not following the instructions and then having a very constantly high levels of glucose. Okay. So the frequency with which the testing is done, what was the nature of treatment first started, whether the patient followed all the instructions, whether they kept the glucose under control or whether they worsened and they required more addition of tablets or substitution with insulin itself. That is very, very important. Okay. So what are all the medications that the patient took is very important. Similarly, for hypertension, any chronic ailment, remember these three questions. One is how it was detected. Two, what was the initial treatment? Three, was there any need for escalation of the drugs? These are the three things you should ask in all chronic ailments like diabetes, hypertension. Okay. So these questions you should be asking this patient and recording and documenting. Okay.
Okay.
Now that the dialysis, you have the case scenario is given that she has been on dialysis for the last 2 years and that too now thrice weekly. So that also
Okay.
requires a little bit of probing and questioning. So what questions you should have asked the patient?
Sir, any adverse events happening during dialysis like hypotension?
Very good. And that before that, what was the necessity for starting the dialysis?
Any
Isn't it?
emergency conditions leading to dialysis?
Yes. So if the patient has been diagnosed to have CKD about say 4 years back with microalbumin or frankalbuminuria, hypertension becoming more and more severe, the nephrologist or the diabetologist has suspected that she is a potential candidate for CKD. And they said, you be prepared, you may be going for dialysis anytime, your GFR is getting lower and lower. So if she has already been warned, then they could have created an AV fistula, and then when the things got worse, they could have straight away started as a supportive measure. Okay. On the contrary, if the patient has not been following up properly, suddenly lands up one day with a severe breathing difficulty.
Okay.
And the lungs are flooded with water, and there is a lot of rales and bronchi. She is in acute pulmonary edema. Then how will you dialyze this patient?
Sir, by IJV.
So you must ask that history about dialysis, whether it was
Okay.
started as a prophylactic supportive measure by creating an AV fistula, anticipating CKD, and then started when the parameters started worsening, or whether it was done as an emergency because of fluid overload, or what are the other indications for such emergency dialysis? One is acute pulmonary edema due to fluid overload. Okay. Any other indications for an acute renal replacement therapy? Hyperkalemia. Very good. Then
Refractory metabolic acidosis.
severe refractory severe metabolic acidosis. Okay. Right. Hypermagnesemia. That is also, what will hypermagnesemia cause?
Muscle weakness.
Muscle weakness. Yeah. Just like when you give magnesium sulfate for your preeclampsia treatment, what you are first monitoring is your patellar reflex because the muscles start losing their tone, isn't it? So the same thing can happen in hypermagnesemia due to CKD also. Okay. Right. Okay. Right. And severe uremia causing encephalopathy. All these things are indications for acute or emergency dialysis in a patient with CKD. Okay. So that history is very, very important. If she says a fistula was created and then she was, because the urine output was coming down, creatinine was going up, it was started as a prophylactic supportive measure, that is altogether a different question. And on the contrary, if it has been started using an IJV catheter or a subclavian catheter for an emergency basis, that is altogether a different scenario. Okay. So what is the difference between the two? Why that history is important? A patient who got AV fistula done, allowed it to mature, allowed it, and with the fistula, she was not on its RRT for almost 4 or 5 months. Then they said, doctor said, finally, no, you can't follow on like this. You have to undergo dialysis. First started with once a week, twice a week, then gradually increased to thrice a week. This is a scenario in one patient. In another patient, diagnosed as a potential candidate for Ckd, suddenly after 2 months of diagnosis lands up with pulmonary edema or hyperkalemia or hypermagnesemia or uremic encephalopathy, requires an emergency dialysis. What is the difference between these two patients? Is the question clear?
Yeah, what will be the outcome? What will be the outcome of these patients?
For IJV catheter patients, they will be more prone for infections and
they are uncompensated. They have already gone to the extreme edge of ESRD, isn't it? They have neglected it so much, their GFR is so low that they cannot excrete any water, and they have gone on for all these complications. Whereas the other one who has had a fistula done, then waited, is a gradual progression. The GFR is still not gone on to extremes of stages. Okay, so that is a very important difference that you should be able to get, information that you will be able to get between by asking this question about the dialysis. Okay, right. So now first challenge here is this patient is now posted for bilateral nephrectomy. What are the indications for bilateral nephrectomy before doing a transplant in a Ckd patient?
Any septic foci?
Excellent. First is the chronic, some infection present, which is not good if you leave it and do a transplant. Why? Why you should remove that septic focus?
It will infect the transplant kidney in future.
What happens after transplantation?
What drugs are they put on?
Patient is on
immunosuppressive.
Patient is going to be on immunosuppressive agents. So already if you harbor an infection, she can go in for septicemia and die. Isn't it?
Okay,
so you must remove. Even a dental caries you should attend. Okay. In those days, before transplant, the patient used to be sent to all departments: gastroenterology, dental, ENT for any sinus infection, gynecology for any uterine infection. So they used, especially if it is a female, they will go through all departments to rule out any septic focus in the body. Okay? Nowadays, because of the availability of good antibiotics and lesser immunosuppression techniques, we are escaping. But if there is a overt infective source in the body, that has to be eliminated. So this may be having a septic focus, perinephric abscess or something, or even I have done a case of bilateral polycystic kidney, huge ones which were occupying all the iliac fossa level. So the surgeon does not have a space to keep the new kidney. So they have to remove both the kidneys first and then do the transplant later on. So with that case scenario only, I gave this scenario to you. Okay. Now, so for that reason, now the patient is going to be operated for removing the septic focus in the kidneys. So how would you give anesthesia for this patient? We'll talk about transplant later. In a deceased donor transplantation discussion, we'll have after completing this.
Okay.
So supposing first this patient is posted for nephrectomy tomorrow. They are sending her to her 2 days prior to your evaluation and plan. You are going to be the anesthetist for this case. How are you going to manage?
But as for preoperative investigations, like CBC, total count, platelets.
No, always when in the exam, if they ask you a question like that, you first identify the problems in this case. Then you go on for your regular. See, preoperative investigations we always do for all cases. But better practice will be to always identify what are all the challenges or problems, enumerate them, then go for description of your preoperative evaluation. Now, in this case, what are all the challenges for you? Number one, she is a long-standing diabetes mellitus patient, right? Number two, she is a non-hypertensive on treatment also. Number three, she is a established CKD patient who requires renal replacement therapy in the form of dialysis, which is done thrice a week. Okay, these are all the three challenges, and she is undergoing a major surgery. It is not a minor surgery. Bilateral nephrectomy is in single sitting. That too, if they want to do it, is quite a challenging job, isn't it? So these are the four challenges before you. So with regard to diabetes, what are all the things that you want to assess in this patient before you start the investigations and all that? What are all the clinical assessments you want to do? What is the most important diabetic complication you want to assess before you even CKD has been already established? Apart from CKD, what is the other thing that you would like to know?
Any autonomic neuropathy.
Autonomic neuropathy. Excellent. So autonomic neuropathy, how do you assess the autonomic neuropathy, whether it is moderate or severe or worse? What simple test will tell you? Supposing you are in the preoperative assessment clinic and this patient has come with these reports. So what questions you will ask to assess the autonomic neuropathy, and what clinical test you can do to assess the autonomic neuropathy?
Changes in heart rate and blood pressure changes.
Resting tachycardia,
Resting
number
and
one.
resting
Okay,
tachycardia.
very good. Then
Orthostatic hypotension will be there, sir.
excellent, very good. Then what, any history first you will start asking the patient? Any complaints patient may have?
Numbness of extremities.
You're always worried about numbness.
What about appetite?
Gastroparesis and bowel and bladder.
GERD
Yes,
features.
satiety.
That's the most simplest thing. Okay, GERD, delayed gastric emptying. Okay, and see sometimes even repeated vomiting because of that. Vomiting
Yes.
may be due to anemia also. And orthostatic, getting giddiness up on getting up from lying position, and always having a sense of palpitation, okay, because of the tachycardia. These are the history that you should ask whether you have all these problems. Then you examine the patient for the resting pulse rate, which is always more than 100. Then what is the simplest test that you can do in your outpatient assessment?
For airway problems, we have to check for prayer sign and palm prints.
We are
No,
talking
he's asking
about
about
autonomic. We are
autonomic.
talking about autonomic neuropathy,
Mm.
ma.
Okay, okay.
Can you do a Valsalva in the clinic itself? The assessment clinic.
Valsalva.
Huh?
Yes,
How
yes.
do you do a Valsalva procedure if you want to assess the severity of a ANP?
We'll ask the patient to hold both his hands together and then try to stretch it. Stretch the hands. So ask the patient to hold both his hands together and then try to stretch it.
Is it Monali Thakur who is answering?
Yes, sir.
Her name is highlighting. It's only Pavitra who is talking. You don't want to show your face also. Okay. Right. So you can ask the what is Valsalva maneuver? This is sometimes, suddenly the examiners are very fond of jumping from one area to another. What is Valsalva maneuver? Valsalva maneuver is a short note question for a theory paper also. So who is Valsalva? What did he describe? And what is the importance of this Valsalva maneuver in diabetic autonomic neuropathy? Arun, who is Valsalva? Italian physician Antonio Valsalva. Okay. And he used this technique to expel the pus from the middle ear. He did not use it for testing the autonomic neuropathy. Okay.
Okay.
And what he did was he asked the patient to exhale against a closed glottis. We want to say in our common parlance, training for evacuating your stools, hardened, constipated stool. When you want to expel out, you strain. That is what is you do by this Valsalva maneuver. Trying to breathe out through a closed glottis. In other words, in Tamil, it is called mucking. Okay, you muckify. Then you increase the intrathoracic pressure so much. So what
Delivery
happens?
also, sir. Delivery also, sir. Delivery also, sir.
Edma?
Delivery.
Delivery.
Delivery of the baby.
Maybe I don't know whether Pavitra is married and delivered or not. So this is a more common day-to-day affair most people would have experienced. So I thought this will be a better example, right? For both for men and women, right? So straining, okay. When you do that, there is an increase in intrathoracic pressure. So initially there will be squeezing of the blood from the veins into the heart. There is an increase in the venous return. So initially increase in the cardiac output. So there is either a normal or slightly decreased pulse rate. Then when you strain more, the intrathoracic pressure does not allow the venous return to come. So the heart starts beating faster to maintain the cardiac output, and the BP goes up. And if the person is without ANS, that is autonomic ANP neuropathy, once they release the pressure, all things settle down and come back to normal. Whereas if the patient is a diabetic patient, there is no increase in blood pressure after this effort, and the tachycardia that sets into maintain the cardiac output does not settle down and come back to normal within the stipulated 1 to 2 minutes. Okay, so that is what is going to happen, which is a very simple test to establish this autonomic neuropathy, which is a very important thing that you have to test in all diabetic patients of long-standing duration. Okay, right.
So actually, theory also they have this question, sir. Tests of autonomic neuropathy in diabetes.
Yes, yes.
Separately for parasympathetic, separately for sympathetic.
Sympathetic,
Heart rate
yes.
response,
Yes.
BP response. I think you should read that more
Yes.
thoroughly.
They repeatedly ask, especially in DNB papers, this is a very, very common question, asked at least once in 2 years or 3 years as a repeat question. Okay, so remember that, right? Okay, so the challenge one is diabetes, the medication, whether any previous history of hypoglycemic spells or ketoacidotic admissions. These are all the questions that you should ask regarding the diabetes mellitus. Hypertension and whether there is any decrease in the visual acuity, indicative of diabetic retinopathy also. And for hypertension, you must again ask for how it was diagnosed, what was the initial BP recorded, what was the initial treatment advice, whether it was only salt restriction, avoiding too much of pickles and papad and all that, or whether it started on medication straight away, and whether it was controlled with that medication, how often you got tested, then was there any need for any additional treatment or addition of extra drugs, and was the blood pressure getting under control or what is consistently increasing, any spells of dizziness or headache persistently happening because of uncontrolled hypertension. All these questions you should ask regarding the second challenge of hypertension. And third challenge of CKD on the renal replacement therapy, I told you the history, whether it was started as a supportive measure on an elective basis or whether it was done as an emergency basis. All these things will give you an idea about the overall control of the comorbidities and their effect on the patient. And lastly, with regard to the bilateral nephrectomy, which is going to be a major surgery, what are the preparations you should do? Is it likely to result in if it is going to be done on the same sitting, is it likely to be causing some blood loss?
Sir,
So we'll avoid fluid overload.
Fluid overload, very good.
So for that, if it is possible, we'll measure the central venous pressure, sir. And then accordingly, we'll give fluid to the patient.
Okay. Now the challenges with the surgery are, it is a major surgery. It is time consuming, likely to be time consuming. And if we want to do it in the same sitting, first you have to put the patient on one lateral and then turn the second lateral position after completing the first side. Then there can be the lot of pain will be there. Electrolyte imbalance can be there, and fluid replacement has to be very judiciously done. Okay. So patient has to be adequately dialyzed before surgery.
24 hours prior to surgery.
And then the effect of any residual heparinization that was done because of the dialysis, all these factors have to be taken care. And then supposing there is a lot of bleeding and you start giving fluids and blood for maintaining the hemodynamic stability, what is the complication that can happen and how can you avoid that on the table?
Giving vasopressor.
Vasopressors is, now I have told you the management. See, there is a lot of bleeding, some adhesion because of the infection. So wherever they try to separate the kidney, all these sites are oozing. So that's quite a sizable amount of blood loss. The patient goes in for some hypotension. So in order to maintain that, you replace volume as well as you are forced to give blood also. In that situation, how can you avoid fluid overloading on the table? I know that most of you as a postgraduate would not have come across unless you are working in an institution where these sort of cases are regularly handled. So I can understand that you would not have had any exposure to such cases. But if such is the situation, at least theory part of it, you should be able to manage. Okay. So in cases where you anticipate a lot of fluid shifts, what are all the preparations
Blood conservation strategies.
Blood conservation strategies. You are not talking about monitoring at all.
Adequate monitoring of JVP.
See, whenever there is likely to be a fluid shift, you must go for a CVP monitoring and intra-arterial line monitoring. Okay, that is the first and foremost thing that you should think of. Okay, and here the kidneys are not working. Patient already has been dialyzed, but until the next dialysis, you cannot remove the fluid from the body. So what is the facility that you have to do on-table fluid removal? Intraoperative hemodiafiltration or hemofiltration. Okay, that is the thing that is available nowadays. So if at all you need to give a lot of fluids and blood, then you can remove the excess fluid on the table itself by connecting to the AV fistula and doing the hemofiltration while the surgery is going on. That facility is available, especially patients who have diabetes mellitus. In my experience, what I have seen is patients who have coronary artery disease and diabetes mellitus with Ckd waiting for transplant, the nephrologist always asks them to undergo CABG so that their heart will be normal. Otherwise, they may die of myocardial infarction post-operatively. So we have referred the patient to the cardiothoracic surgeon for CABG, and while doing CABG, they always remove the excess fluid by hemofiltration and complete the CABG surgery without any complication and send the patient back. After 2 days or 3 days, we can start the regular dialysis, and once the cardiac issue is settled, we can go for transplant and complete the transplant. So I have done such cases also, about at least half a dozen of them I have done, managed. So this is the technique that you have to remember. Hemofiltration can be done intraoperatively to remove the excess fluid. Okay? So this is the challenge that you have to. So otherwise it is same for any non-transplant surgery in a patient on hemodialysis. One thing is, make sure that the patient is adequately dialyzed, not on hyperkalemia, ABG is normal, no acidosis. Then try to give the minimal drugs because drugs are dependent on elimination only for with the dialysis. So go for minimal drugs, give adequate antibiotic cover, go for the surgery, complete the surgery, and if there is any, vigilant invasive monitoring is very much essential in these cases. That is the patch that you have to do.
Okay.
Now this patient has been successfully operated for bilateral nephrectomy. Now after 1 month of all the wounds are healed, now patient is waiting for deceased donor, and suddenly one day you get a call that some donor kidney is available. Okay. So what are the challenges in doing a deceased donor transplantation compared to a live donor transplantation?
This deceased donor transplant will be taken as an emergency surgery, sir.
Okay.
So the patient will
Quasi
be
emergency. It is not always the immediate emergency. You should call it as a quasi emergency because once the somebody has given a consent for a brain dead donor, the organization of organ retrieval and then preservation, and then you get a call. The retrieving hospital may be somewhere, and the organ has to be transported. So by the time you will get some intimation that your kidney is available, you get ready. So at least you will get a gap of 8 to 10 hours. It is not always that next half an hour you are going to be operated. So you can call it as a quasi emergency and not as a real life threatening emergency. Okay.
okay.
Right.
Within that
Okay.
8 to 10 hours, is it possible to know the genetic makeup of the kidney of the deceased deceased donor? Because if we take a known donor, a live donor, then we do all the investigations in the live donor also, then we put the genetic makeup also. So if we take it from a deceased donor, then the chances of rejection are more than a live donor. Like intra complications like anaphylaxis or whatever, so graft rejection and all. Is it more, the chances of this
Are
is
you
more
somebody
compared to
who is asking this?
Monali Thakur?
Monali Thakur, can you be little louder? Your mic is very feeble. What is your question?
So are chances of the graft getting rejected more in case of a diseased donor because we don't get that enough time to do the genetic makeup and all? Like in case of live donor.
No. It is not like that. Not the genetic makeup and all that. Unless first of all they do what is called the group matching. Let's say you have the same group, you will not be allowed to have the transplantation. Second thing is a tissue matching done. Nowadays facilities are there for tissue matching, which will tell whether it is less than 20% or more than 20%. If that is there, you can go ahead and do. The only problem is the on-table urine output may not be as always seen in the live donor transplantation. So patient, because of the preservation and waiting, they may have to, the opening up of the kidney may take a little time. So the only problem you have to anticipate is failure of on-table urine output, which may warrant a post-op dialysis for a couple of days until the kidney starts working. So that is the problem. Of course, as you say, rejection chances are little higher compared to the elective, but overall incidence is same. Even in elective cases where you have a full house matching and do, I have seen on-table rejection. Mother giving to daughter what is the so-called full house match with HLA compatibility. They also, due to some unknown reason, rejections happen. So it is not grossly very high compared to the elective cases. Okay.
Okay, sir.
Right. So that is the. So it is a quasi emergency preparation, and so sometimes patient might be waiting for a next dialysis. Before that, they may need to. So they have to go for an emergency dialysis if there is a hyperkalemia or there is acidosis, and heparin-free dialysis can be done. What is the alternate drugs that you can use? Supposing a patient is allergic to heparin, what are the other options you have to keep the anticoagulation going? Is it always necessary to use only heparin? There are very rare cases where patients can be allergic to heparin. So in that situation, what will you do? Any alternate drugs available to maintain the anticoagulation?
Lanaproid, levirudin, sir.
Lanaproid, levirudin, they are all very short acting. But the recommended drugs are citrate and prostacyclin. Prostacyclin is an antiplatelet action is there. So there are commercially available prostacyclin preparations are there which can be as good as heparin. So in patients who have heparin allergy or reactions to heparin, you can use these two drugs. What is the mechanism? How does citrate help in maintaining anticoagulation?
Calcium chelation, sir.
Huh?
Calcium chelation.
Yeah, it binds to calcium, chelating the calcium. Okay, calcium is important for coagulation. Okay, so what are the three important things that are required for coagulation? One is calcium. What are the other two? Platelets and clotting factors. These are the three trinities for coagulation. Platelet, number one, clotting factors, all the 1 to 13 clotting factors, and calcium. Of course, calcium is also included in that, but it is not really a protein. So you can remember these three as a trinity of coagulation: platelets, clotting factors, and calcium. Okay. So if you bind that calcium, it will prevent the clotting steps or cascade going on. So that is one method. Whereas prostacyclin, by inhibiting the platelet action, it helps in anticoagulation. Whereas heparin, what is the mechanism of heparin action, which is commonly used everywhere?
Antithrombin 3.
Antithrombin, factor 10A
Factor
also to some extent, and protein C, protein
Yeah.
S, all these things are all blocked. Okay, so that is how, enhanced. That is how it is causing the anticoagulation effect, right? Okay. So there may be a need for emergency short-term dialysis, which can be done with the heparin-free method, and then you have to go for. So what are the challenges in the donor anesthesia? When you talk about deceased donor transplantation, commonly, this is also a question in your theory paper, management of organ donor anesthesia. It's one of the common questions that is now repeatedly asked in your theory papers also. So supposing you are given the responsibility of anesthetizing the donor, a brain dead donor with a beating heart, how will you manage the donor?
Hemodynamic stability maintenance is very important, sir.
Very good, excellent.
Urine output should be maintained at a certain.
What is rule of 100?
Systemic pressure systolic pressure more than 100 mmHg, sir.
Okay.
Urine output more than 100 ml per hour.
Very good.
PaO2 more than 100 mmHg, sir.
Very
Hemoglobin have to be 100 gram per liter, sir.
Very good. These four things are there. Any new addition to these four things which are included in the rule of 100? The latest addition is blood sugar around 100. 100 or less than 100. Okay. So glycemic control also has been included to the rule of 100. So the existing four things: BP, PaO2, urine output, hemoglobin. These were the four things which were initially included in the rule of 100, to which now they have added the blood glucose also. So severe hyperglycemia or hypoglycemia to be avoided, and blood sugar to be around or 100 milligrams per deciliter. Okay. Right. So any other additional drugs or treatment to be given in management of a donor?
Hormones like thyroxine.
Hormone, yes, excellent. Hormones like thyroxine and
vasopressin.
cortisol, methylprednisolone. These are the two things which have to be thought of, and you have to maintain that. And what about the temperature? Can you have hypothermia?
Yes.
Huh?
To prevent
They are prone for hypothermia. So you have to maintain normothermia. You can't avoid even hypothermia after the harvesting may be good for the preservation of the organ, but not while the patient is on. When you are harvesting, it is preferable not to go for hypothermia. Okay. Which organ will be harvested? So nowadays they do multiple organ retrieval. So which organ is the first to be retrieved?
Kidney, sir. Kidney followed by liver, followed by lungs and heart.
Heart
Sir.
and lungs, sir.
Is it Pratik Shukla answering?
Yes, sir.
It's not
Sir,
kidney.
first we have to harvest heart and lungs,
Yeah,
sir.
it is always the heart and lungs first they do, then the which
Liver,
organ?
pancreas,
Liver,
small
liver,
intestine.
pancreas, small intestine, kidney,
Finally, kidney, and lastly, cornea and skin, sir.
skin. Excellent. So this is the order. Even though we may be thinking that once you remove the heart, how will the kidney survive? That is because the kidney has got a longer tolerance for hypoxemia. Okay, so but what they do is they start using the preservative in situ, so they can start perfusing in situ and then retrieve the organ. Okay, so this is the order that sometimes they may be asking you, especially if the anesthetist happens to handle a lot of brain dead donors, then they will be definitely asking you all these questions. Okay, so it is a not only laparotomy, it will be a sternotomy if it is including heart and lung transplant organ retrieval. It will be an extensive incision right from sternum up to the pubic symphysis. A midline incision will be made and all the organs will be retrieved. Okay, so so after retrieval of the organ, the intubation will come and the anesthesia has to be done. So the difference between a live donor transplant and here it is only a single theater. The organ is going to come in a box. Okay, so unlike live donor transplantation where you require a twin theater with an intercommunicating door, that is not required for a deceased donor transplantation. Okay, so the same, but otherwise the same requirements of how to manage a donor, I mean recipient, all the same. So can you quickly enumerate what are all the preparations you will do in the recipient for deceased donor organ transplantation? Intimation comes, it's a quasi-emergency. Patient has been quickly dialyzed. What are all the pre-op urgent investigations you will do?
Sir, serum potassium, sir.
Potassium, very much, very important. Right, then?
ABG.
ABG to assess the acid-base status. Excellent. Then?
Sir,
blood sugar, diabetic patient. So CBG or blood sugar. Okay. She should not be in too much of low sugar values. Okay. And ketones.
And CBC for hemoglobin.
Hemoglobin.
And
Yes.
platelets.
Okay. Right. Now, what are the intraoperative precautions you will have to take?
History of intakes, oral intakes, sir.
Yeah, that's why the quasi-emergency. So if they are already taken any food, you have to go for rapid sequence induction. Yes, correct. Okay. So food intake time also is very important. Right.
Coagulation profile.
Coagulation profile, all that, of course, they would have done it because she is on thrice weekly dialysis. All those things would have been done correctly. Right. So patient is on table. Now tell me, what are the steps in anesthetizing this patient?
First, we have to give sedation, sir. Anti-Sialagogue have to be given, sir. Glycopyrrolate. And Midazolam 0.5 mg per kg have to be given, sir. And the induction have to be done with propofol, sir. Propofol or for inhalational nitrous oxide plus O2 plus isoflurane have to be given, sir.
It's for maintenance or during induction itself?
For maintenance, sir.
Maintenance.
If serum potassium is less than 5.5, we can give succinylcholine for neuromuscular blockade, sir. After intubation, maintenance have to be done with nitrous oxide, O2, and isoflurane, sir.
Okay. So, how much of fluids you will give? That is the most challenging thing in any transplant recipient. What fluid to be given, how much to be given before clamp release and anastomosis and clamp release, how much you will give after clamp release. That is the most tricky thing in the management.
Okay, sir.
So how will you manage the fluid before the anastomosis and clamp release, and how will you manage the fluid after clamp release? What are all the fluids which are safe?
Sir, normal saline, sir.
Hmm.
Ringer lactate can be given if serum electrolyte potassium is less than 5.5, sir. Colloids should not be given, sir.
But what is the risk of giving ringer lactate in the pre-clamp release stage? At the after clamp release, what is likely to happen to potassium?
Sir, arrhythmia.
Increase.
Why there is a chance of hyperkalemia after clamp release? What is the preservative solution composition? Preservative solution has a high potassium value. Okay, so better to avoid any potassium containing solution in the pre-clamp release time, because
Okay,
you are going to get an increase in potassium automatically by the preservative fluid getting flushed into the systemic circulation of the recipient on clamp release. So if you already give, just because the starting potassium was only 5 and you give ringer lactate, and intraoperatively, if you have not checked and it goes to 5.5, and after clamp release, all the preservative fluid which had a heavy dose of potassium also comes into the circulation. I have had one case of cardiac arrest because of hyperkalemia after clamp release. Not because I gave ringer lactate, but purely because the preservative fluid coming into the circulation. Okay, and when we took the measurement of potassium, it was 6.8. But luckily we were able to revive because we suspected and immediately treated. What is the treatment of emergency hyperkalemia?
Calcium gluconate.
Calcium, 10%
calcium
calcium gluconate, sir.
Okay, how does it help?
Stabilizing the heart. Depolarization.
Stabilizes the heart.
Membrane
stabilization.
This is the answer given by every student. Membrane stabilization stabilizes the heart, but what is the exact mechanism? See, your potassium is beyond the higher normal level. It is 6.87, whatever it is. You are giving 10 ml of 10% glucose, calcium gluconate. How is it going to help? How does it stabilize, as you say? What will, supposing you take the potassium after administration of calcium, what will be the potassium value? Will it come back to below 5.5 or will it remain still high?
Still high.
It has to decrease, isn't it? How does it decrease?
Insulin plus beta.
We are not giving insulin, Baba. We are giving only 10% calcium gluconate.
Chelation.
What is the mechanism? Chelation. Who is saying chelation?
Yes, sir. Purnima.
Is it Purnima? No.
Yes, sir,
Chelation
yes.
is binding.
Fine.
See, what is the charge in calcium?
Positive.
Positive.
2 plus.
2 plus. It is a positive ion. Potassium?
1 plus.
Potassium is also
1 plus.
positive. Okay.
Yes, sir.
1 plus or 2 plus, both are positively charged ions, correct?
Yes, sir.
So, body always tries to maintain electroneutrality. And potassium, is it an intracellular ion or an extracellular ion? Intracellular ion. So, what will happen? Calcium, is it an extracellular or an intracellular? Extracellular. Okay. So, calcium, when you push it in the extracellular space, it doesn't have space to remain there. So, what it has to do is push the fellow who belongs to the intracellular compartment to maintain the neutrality. Okay, so that is how it is happened. That is how it works, by pushing back the potassium, just like what you do when you give a combination of glucose and insulin. The same mechanism works here also. Okay, it drives back the potassium into the intracellular compartment where it belongs to by a sudden surge of calcium with a positive ion charge. Okay, to maintain the electron neutrality, it does this work. That is how the calcium works. Only in emergency cases you have to do. Whereas if it's a chronic hyperkalemia, what are the other options? Or what is the other next option to calcium in an emergency setting of hyperkalemia?
Insulin
Insulin will take a little more time.
Any
Actually,
other bronchodilators?
Beta agonist, sir.
no. Bronchodilator, so insulin, glucose infusion, all these things are
Soda
slow treatment. Binding is very, very slow. Binding
Soda bicarb, sir.
bicarb, soda bicarb. That is the next immediate next. See, both of them will, bicarb will push again. This sodium increase in the bicarb, that is a positively charged ion. That will push the potassium inside. Okay. So both of them work. We normally don't use bicarb routinely because it is going to release more carbon dioxide and create a intracellular acidosis in the brain. So that is the reason why we don't use it. But in case calcium does not effectively reduce the potassium, immediately you can safely give bicarbonate to push back the potassium and prevent a life-threatening arrhythmia or cardiac arrest. Okay. So the emergency treatment of hyperkalemia is, first is calcium gluconate, safe and reliable. Next is sodium bicarbonate, 50 ml, 8.4% weight by volume. Next is glucose insulin infusion, which is going to take at least 15 to 20 minutes. It's not as quick acting as your calcium and bicarb. And next is will be your binding agents, and last will be hemodialysis. Okay, this is the order in which you have to tell the treatment. This is a very common short note question in your theory paper also. So you have to go in that order, understand the concept and treat it. Okay, right. Okay. So these are the things that you have to take care. And as I said earlier, on-table urine output may not be always present in deceased donor transplantation. So you have to be very, very careful in fluid management. So some people use CUP catheters for these cases for the recipient, but the validity of CUP in these patients is sometimes nowadays questioned generally. So it is more by watching the blood loss and other things, you go for that. But it will always be safe to give not more than 1 to 1.5 liters before clamp release. Maximum you give must be only 1,500 ml. Don't give more than that. And don't give too much of sodium load also. Don't give all the 4,500 as normal saline, because you will be causing a hyperchloremic metabolic acidosis. So you go for half normal saline if the sodium load is high, or if the patient's blood pressure is very high, always go for half normal saline right from the beginning. Okay, so that is how you manage these cases. And on the after clamp release, if the urine output is good, then measure the urine output and then give the output of previous hour plus 100 ml as your maintenance solution. Okay, that is how you manage the fluid. And of course, take care of the pain, maintain carbon dioxide level within normal limits. And some people give steroids on the table. Methylprednisolone is given before clamp release. Some people use mannitol, some people use Lasix, all these things before clamp release to enhance the urine output, which is done mainly in cadaveric or brain dead deceased donor. I should not use word cadaveric, deceased donor transplantation. Okay, so this is the thing. So shall we go for a presentation?
Yes, sir. Yes, sir.
Right.
Yes, sir. Yes, sir.
You have enabled the presentation?
Yes, please, sir. It's enabled, sir.
Yeah, okay.
Sir, post-op, sir?
Post-op, anything specific you want to say? This is mostly barrier nursing and strict asepsis with watch on the urine output, pain relief, immunosuppression. Of course, immunosuppression is started before surgery itself. and continue with the
Introp.
post-op. Not intra-op, nobody gives immunosuppression. It is given as a pre-medication, along with pre-medication, as well as in the post-operative, depending upon the urine output and the maintenance. Okay. There are, of course, complications with the drugs that are used for immunosuppression, like cyclosporin has its own nephrotoxicity, and the other drugs like steroids, and they can, especially in a diabetic patient, they can make the blood sugar go high up. So you have to use insulin to control that. So all those problems are there. Okay. That's the secondary to that.
Once there was one question on use of regional anesthesia for recipient renal transplant, sir.
Renal transplant. That has been there. That is a debated issue in the sense some centers have performed a continuous epidural as a method of choice to avoid GA and polypharmacy. But in my experience, I have done a couple of cases in the regional because the lung and I had a patient with cystic disease all over the body, and the lung also had a cystic disease, and so he was not a fit candidate for GA at all. So I had to do it under epidural. But the problem in epidural is the hypotension that can happen, and you cannot manipulate the BP. When you give GA, you can always increase the BP by lightening the plane of anesthesia, especially during clamp release, because the new kidney is pressure dependent. It doesn't have the auto regulation like a normal kidney. So during that time, if your BP is slightly higher, it is always good for good perfusion, which you cannot do unless you use a vasopressor, which will cause tachycardia and unwanted side effects. Whereas here, by just manipulating the plane of anesthesia, you can always increase the blood pressure without any need for extraneous support. So,
combine GA and epidural we can give for analgesia.
Pardon?
So combine GA plus epidural for analgesia.
Yeah, some centers do it as for a pain relief, but the major thing is majority of the patients somehow, because of they are on heavy steroid dosage, the recipients don't complain of that much of pain.
Correct.
So the many centers, fear of infection also, they don't use any epidural in a recipient because they are going to be on immunosuppression, and if you are not very careful with your aseptic techniques, then you can land up with a meningitis or some problem there. Okay, so that is how. Just 1 second. Ravel, நான் கூப்பிட்டுமா கிளாஸ்ல இருக்கேன். Okay, no problem. So that is anything else, Vasanthi, you want to add? Hello?
I think we covered everything, sir.
Okay.
Yeah, thank you, sir.
So I'll go for the presentation. Hope everyone is able to see.
Yes, sir. Yes, sir.
Okay. This is presentation which is available in YouTube thanks to Kamachi for uploading it almost 1 year back. But I have added a few slides little later. So the initial part I will go a little faster. So for some of you might have even seen it in the YouTube. So the definition of Ckd is a common question they may ask you. It is defined as a GFR of less than 60 ml per minute in a 1.73 square meter for 3 months or more, irrespective of the cause. That is the definition. Or a kidney damage leading to a decrease in GFR, and everything should be more than 3 months. If it is less than 3 months, I mean, it is called acute kidney injury. It is not called a chronic kidney disease. So you have to know the duration. Time duration is very important. The damage may be manifested as abnormal composition of blood and urine, or changes in the radiological imaging or histology of the kidney. Sometimes they do a renal biopsy also. So the stages, all of you know what is the GFR level. So it is staged only on GFR level. So more than 90 is supposed to be stage 1. 80, of course, normal should be 120, but nobody has 120. So roughly about 90, anywhere between 90 to 120 is normal. then it gradually decreases, and when you say ESRD, it is less than 15 ml per minute per this body weight surface area. The various etiologies are common. The number one cause is diabetic nephropathy. Then there is hypertensive, glomerulonephritis, renovascular, polycystic kidney disease, reflex nephropathy, HIV associated, allograft failure. So most of these things are all, but the number one culprit is diabetic. And the next common what I have seen is the immunomediated IgA nephropathy, especially in younger people. If they develop a CKD, it is mainly immunomediated. And GFR, there are two measurements. One is measured GFR, another is the estimated GFR. Okay, so you must be able to differentiate between two. The measurement you do by doing the creatinine or inulin clearance, which is by collecting the urine, measuring that, and then measuring the plasma value, and then calculating it. Whereas the coag graft is made from the serum values of creatinine with the parameters used like age, weight, etc. So that is measured and estimated. There are two things which you should remember. So what adaptations the body undergoes is in patients with CKD is until very late you will not get any urea or creatinine rise. So you should not be misled by that. Until 75% of the nephrons lose their function, urea creatinine value may remain normal. So that you should not be misled or be cheated by that, seeking that, oh, urea creatinine, okay, the patient should be all right. Not like that. And potassium levels are also maintained very normally till the GFR almost reduces to 10%. This is by the action of aldosterone, which makes it increase loss. And the maintenance of sodium also is dependent on the fluid status. So these adaptations body undergoes, which can mislead you from diagnosing CKD. The complications, each system I have already discussed in the last my class. Of course, it was long back. I remember it by the mnemonic chief game. Chief C stands for CVS, which produces hypertension, LVH due to salt and water retention, cardiomyopathy, and accelerated atherosclerosis. With hematology, you can have anemia and coagulopathy. Both can happen. Both hemostasis can have failed coagulation. And with regard to immune system, patient may have immunosuppression because of uremia or because of the drugs that are given. Sometimes in the IgA cases, they try pulse therapy to revive the function. So patient may be on steroids and immunosuppressions as a trial method to restore the kidney function, especially in IgA nephropathy. And then electrolyte changes, you can have hyperkalemia, hyperphosphatemia, hypermagnesemia, and calcium alone will be decreasing. They may have hypocalcemia. All these things can lead to cardiac arrhythmias as well as muscular weakness. Then fluid imbalance, patient may be either overloaded or dehydrated also. Initial stages, there will be a hypersecretion, so patient will usually go for dehydration, which will viciously lead to reduced renal perfusion and problems. Gastrointestinal, there can be delayed emptying. Nausea, vomiting is very common because of the gastric irritation by the urea. And acidosis and autonomic neuropathy, which are very common, especially per se due to kidney disease, as well as if the diabetes is there, autonomic neuropathy will set in much more faster. To this, you can now add the central nervous system problems also, like the seizures, coma, the irritability. All these things are central nervous system problems, which are secondary in this CKD. Musculoskeletal system, you can develop renal osteodystrophy and rhabdomyolysis. And endocrine system, you can develop hyperparathyroid parathyroid levels, vitamin D deficiency, and patients who are non-diabetic after CKD, they can develop diabetes also. So even though diabetes is considered the main reason for CKD, sometimes patients who are non-diabetic developing CKD also can become diabetic later on because of the CKD. So that with the first letter, I remember it by chief game, CHIEF, GAME. So in history taking, first patient may complain of gradual decrease in urine output, loss of appetite, nausea, vomiting, recent onset hypertension, may be suffering from uncontrolled diabetes, may complain of swelling morning with pedal edema, breathlessness on exertion, bleeding episodes, insomnia, irritability, pruritus, and any problems with renal replacement therapy. All this history you have to get from the patient. And ask for duration and severity of comorbidities like hypertension, diabetes, urological problem, drug intake, especially patients with joint problems who have been taking NSAIDs for a number of years. They finally come and land up with a CKD. So it's mainly drug induced. And to this nowadays, we have to add native treatment also, especially after the COVID and other things. Lot of drugs are being prescribed for as a remedy for that, which may have bearing on the kidney function. And if the patient is already on renal replacement therapy, ask for indication for renal replacement, whether it is initiated as an emergency or elective after AVF fistula creation, and any hemodynamic instability during initial stages. So majority of the patients, when they are put on hemodialysis, the first 2 or 3 sittings will be very stormy. They will have sudden hypotension. They will stop the dialysis, rush in 1 liter of fluid, restore the BP. All these things, history may be there. But youngsters usually withstand this very well. But patients with aged patients with cardiac comorbidities, they may have this sort of problems. And how frequently they require dialysis, what is the weight gain, any history of pulmonary edema due to skipping of dialysis, how much of fluid reduction is done, what is the pre-dialysis weight and post-dialysis weight is a very important information. And quantity of native urine. This is another important information that you should get. Some patients, even with an established CKD, may have a urine output of 1.5 liters per day. So they never go in for pulmonary edema or fluid overload. They are able to excrete the water content. But if you measure the specific gravity, it will be like a pure water. But the other contents may not be there. So those patients you can consider as a blessing for you, because you can give fluids freely on the table also. They will not have any problem. But the problem in them will be judging whether it is a native urine or the new kidney urine in the post-transplant state. That will be a headache for your nephrologist. So they have to take a call on that in replacing the fluid. Now coming to the general examination, look at the eyelid, facial edema, pedal edema, anemia, scratch marks and vitals, and go for CVS, look for heart size in X-ray and clinical examination to rule out pericarditis or myopathy, whether they are in failure, and respiratory rate, lung signs due to fluid excess in respiratory system. Abdomen, look for renal swelling. Sometimes they may have a perinephric abscess or a polycystic kidney, as I told you, or it may be an enlarged bladder because of prostate in the male, or some obstruction or any free fluid. CNS, say check for sensation and motor examination for neuropathy, and AVF fistula site, functional status, and presence of any gigantism, Rui, thrill, all these things should be palpated. CBC, look for anemia, infection, and platelet function. Renal function test, urea creatinine ratio, urine microscopy for albumin or overt albuminuria, culture and sensitivity to rule out any infection. X-ray chest, look for, of course, cardiomegaly and fluid in the lungs. EKG, there may be LVH, hyperkalemic features, or silent MI may be there, especially in diabetic patients. Echo, cardiac function, size, pulmonary pressure, pericardial fluid. USG, abdomen, renal parenchymal appearance, bladder size, and prostate in male. And serum electrolytes, all these things you have to. What is this suddenly coming here? Happened. It came in and it is not moving. So metabolic acidosis. So preparation, You have to anemia correction with iron and folic acid, parenteral iron if necessary, erythropoietin, control of blood pressure, adjustment of diabetic medications, and nutrition, protein point to be restricted. You have to give restricted protein, otherwise urea is likely to go up. And restrict phosphate is a very important thing. That is one of the causes of worsening of the CKD, which I will show you in a later slide. And renal replacement therapy, whenever is indicated, hemodialysis either through emergency IJV or elective after AVF. And peritoneal dialysis in those patients who do not withstand hemodialysis, who have problems because of that. The anesthetic management, you have to have preoperative orders, NPO for 6 hours, and hemodialysis to be done 24 hours prior, serum potassium to be checked, continue antibiotics, antihypertensives, except ACE and ARPs, skip oral hypoglycemic agents, aspiration prophylaxis, anxiolytics, immunosuppressives. These are all the things that you have to give. Intraoperative, avoid all drugs eliminated renally. So there is a change in pharmacodynamics with increase in volume of distribution, decreased protein binding. So induction agent of choice can be propofol, thipentone, or etomidate. Saxa if the potassium is less than 5. Atracurium and cisatracurium, because they don't depend on the kidney, are the safest relaxants. And fentanyl can be safe. Avoid morphine and pethidine because they are also renally eliminated. And the use of isoflurane, sevoflurane as inhalation agent. Titrate neostigmine. Don't blindly give 2.5 milligram because especially with the use of satracurium and cisatracurium, you may not require the full dose. And if you give the full dose as a routine in all these cases, this is renally excreted, so you may have a delayed bradycardia and all the muscarinic features of neostigmine in the ward. And neostigmine itself can be cause of muscle weakness. So the points to remember in the anesthetic management: avoid BP cuff on the fistula limb. This is a very important point you have to remember. Fluids, you can give normal doses in patients who have sufficient native urine output and not having any edema. Restrict only in those with negligible output. This is the dictum that you have to follow. Avoid potassium containing IV fluids. Avoid too much of normal saline, half normal saline to be preferred. Beware of hypotension, arrhythmia during clamp release after vascular anastomosis during transplant. Now, what are all the types of CKD patients you can encounter in your practice? They can be moderate CKD with a GFR of 30 to 60 ml, not at present requiring any replacement therapy, but conservatively managed when they come for an incidental surgery. That is one category. Second is ESRD, end-stage renal disease patient who is already on a renal replacement therapy in the form of twice or thrice weekly dialysis, and they come for non-renal procedures like what we have described now with the bilateral nephrectomy case. ESRD patients on peritoneal dialysis coming for non-renal, non-transplant surgery. Then any type of patients, any type of the above patients coming for emergency surgical procedures like a trauma or acute abdomen or obstetric emergencies. Post-renal transplant patient coming for complications due to transplant procedure or an incidental surgery. Probably you might have had a small hernia which was missed. After transplant, it becomes bigger. So after 2 years of transplant, he wants to get that hernia done. So that sort of patient also you can have. So these are all the categories you have to remember. Moderate patient with a still a GFR, preserved GFR 30 to 60 ml, not on renal replacement therapy. They are the most challenging patient when they come for incidental surgery, because the primary aim is to preserve whatever function is there and prevent an acute renal failure. So that is the most challenging thing. Strict asepsis as they are immunocompromised. Judicious fluid management to avoid under or over hydration. Avoidance of prolonged intraoperative hypertension. Avoid unnecessary blood transfusions if they are likely to undergo renal transplant. And facilities for emergency hemodialysis should be available in case of acute shutdown. and regional anesthesia can be performed provided severe hypotension is avoided. For example, any procedure in the leg, supposing a patient with CKD 30 to 60 ml GFR comes with a fracture fibula, both bones, lower limb. You can safely give a low spinal without any problem and use vasopressor for maintaining blood pressure instead of rushing fluid. Okay, so there is no contraindication for a regional technique in this patient. ESRD patients who are already on RRT in the form of twice or thrice weekly hemodialysis, when they come for non-renal surgery, ideally they should have a dialysis done 24 hours before. Avoid again IV line and BP cuff on the AV fistula limb. Strict asepsis. Checks potassium. Caution when using Saxa. You can still give both RA and GA depending upon the nature of the surgery. Again, judicious fluid administration. Check the functional status of AV fistula both intraoperatively and at the end of the surgery, because that is the life-saving thing for them. They have to undergo post-operative dialysis. So make sure that the fistula is always preserved properly. And patients who are on already coming with a dialysis renal replacement therapy coming for transplantation, there are different types of transplantation: live related donor, live unrelated donor, deceased heart beating donor, deceased non-heart beating donor. That is, even after cardiac arrest, now they are retrieving organs. Up to 30 minutes you can do the retrieval and use those organs if the patient has given a consent preoperatively that you can take my organs after my death. And incompatible blood group and paired exchange donors, where even if you don't get the same blood group, you can do a plasmapheresis and then do the transplant. And that is where incompatible blood group donor after plasmapheresis. And renal transplantation, related or unrelated, it's a you have to first identify a suitable donor with the same blood group. Their age should be between 18 to 65. Controlled hypertension or diabetes mellitus. Any one comorbidity is accepted, but you have to evaluate the renal function in them. And preliminary HLA matching and tissue matching is also done. Preoperative evaluation of the donor, routine investigations as for any surgery, including the renal angiogram to assess the number of the arteries perfusing the kidney as well as the length and the length of the artery and vein. And final cross matching is done 48 hours before surgery. It should come as negative. And renal transplantation, and a recipient evaluated routinely as for any major surgery. They should be dialyzed before 24 hours. Serum potassium to be checked before shifting to OT. FTO guidelines same for any elective procedure. But only thing, donor has to be hydrated with 1 to 2 liters of normal saline during the period of starvation. And preoperative night sedation can be given for both the donor and recipient with alprazolam. Aspiration prophylaxis for recipient is very important, but avoid ranitidine in them. And continuing with that, you need a twin operating theater with the interconnection door, or donor anesthetic management, routine GA with all precautions, because it has to be done on the kidney position, the lateral position with the kidney bridge raised. It is uncomfortable to do it under regional, so always it is GA. And adequate hydration to maintain urine output more than 1 ml per hour in the donor. And mannitol 0.25 gram per kg to be started before the surgeon starts the pedicle, that is identifying the artery and vein. Always avoid hypotension in the donor and maintain normal ABG. And graft preservation, form ischemia time is from the time the donor vessels are clamped till the preservative flushing is started. That is called the warm ischemia time. It should be between the maximum 5 minutes time. It should start perfusion. And cold ischemia, from the time the cold preservative flush is started till the anastomosis in the recipient is completed and reperfusion occurs. It can be 20 minutes in live donor surgery, or it can be the 3 days, 4 days in a deceased donor, because that will be kept in perfusion and then The anastomosis will be done only after the suitable recipient is identified. So cold ischemia time is very prolonged in deceased donor program since immediate transplant does not happen. And that is the reason why the kidney may not function on the table. The preservative fluid composition differs from center to center, but the basic fluid is the ringer lactate at 4 degree temperature centigrade. 20 ml of KCl is added, 30 ml of lignocaine, which should be preservative free. So xylacod is only added. Piperine may be added for vasodilatation. Dextrose 25% is added, and heparin 5000 units may be there. All these things are variable because each center may have a different one. And the recipient management, it's a routine GA, as Dr. Vasanthi said. Some centers practice regional, but I'm not in favor of that. And no IV line or BP cuff on the AV fistula lump. All 5 basic monitors: SpO2, EKG, NIBP, ETCO2, temperature, plus neuromuscular monitor also will be very helpful in assessing the requirement of non-depolarizing muscle relaxant. Aseptic precautions is a must. Induction agent propofol, especially in patients who have very severe hypertension. With some patients may be treated with even 3 drugs because of severe hypertension, which is induced by the kidney disease. They all do well with propofol. And relaxant of choice is cisatracurium to avoid the histamine release. Analgesia, fentanyl, maintenance control ventilation with oxygen nitrous oxide and isoflurane or sevoflurane. And ultimately titrate neostigmine during reversal. Now, continuing with the recipient anesthesia, fluid restriction: 1 liter of normal saline before clamp release. Avoid potassium containing fluids. Use half normal if there is cardiac ailment. Fluid replacement after anastomosis based on urine output plus 100 ml. Vigilance needed at the time of clamp release for sudden hypotension, hyperkalemia, and arrhythmia. Mild hypertension is always preferred as transplanted kidney function is pressure and volume dependent. Barrier nursing of the recipient postoperatively, and of course normal analgesics can be sufficient for pain relief. Now coming to the deceased heart beating donor, brain dead patients who are on life support are the donors whose relatives would have given consent. Organ harvest requires anesthesia to suppress spinal reflexes. Maintenance of hemodynamic stability is important. Rule of 100, systolic pressure, which all we described, hemoglobin. To this only the recent addition is the glycemia, that is the glucose should be 100 milligram per deciliter. Problems like hypertension, arrhythmia, disseminated intravascular coagulation, diabetes insipidus, low urine output have to be managed successfully. And recipient anesthesia and a deceased donor transplant has the following challenges. It is a quasi-emergency. Patient may be in full stomach, may need urgent dialysis. Heparin-free dialysis is done. On-table urine output may not happen, so patient may require post-op dialysis. And so for that, you have to watch the AV fistula and preserve it during the intraoperative period. And organ procurement, of course, there are certain rules which are followed, which is called the Maastricht classification, where this classification is used to find out how useful the organ will be. The class 1, the patient comes dead on arrival. The situation is not controlled. So the organs that can be procured are heart valves and cornea. So you can't take the other organs when the patient arrives so corneal harvesting can be done. You can take the heart and use the heart valves as instead of a prosthetic heart valve, we can use it as a natural heart valve for replacement. The second category is patients who have not been successfully resuscitated. Again, the situation is under uncontrolled situation where you can harvest the kidney. And the third one is anticipated cardiac arrest, which is a controlled situation. You can take all organs except heart. And in cardiac arrest brain dead donor, control all organs you can take, now including the heart. unexpected cardiac arrest in hospital, uncontrolled all organs except heart. So these are the classification by Maastricht. And of course, this is not of great use for us. It is mainly for the retrieving team. So the order of procuring the non-heart beating donor, first is heart and lungs, followed by liver, pancreas, small intestine, next both kidneys, and lastly cornea and skin. So the anesthesiologist who is going to manage the organ donation, the dead donor rule requires that patient must be declared dead before the removal of any life-sustaining organs. Non-heart beating organ donor protocols are there, which we are not going to worry. This is an incompatible donor where paired matching is done. I will not waste time that. And plasmapheresis can be done for incompatible blood group. So you remove the antigen from that and then do the transplant. These are the people who did this. Patient on peritoneal indication dialysis, the indications are the patient who cannot tolerate hemodialysis because of congestive cardiac failure or extensive vascular disease where AV fistula is not properly working after repeated attempts. And here the mechanism is peritoneum acts as a membrane to filter the solutes by diffusion. 3 to 4 cycles per day is needed. The peritoneal dialysis is classified as continuous peritoneal dialysis or cyclical peritoneal dialysis or automated peritoneal dialysis, which I will show in a different slide. So if the patient with the PD comes for renal transplant, check the efficacy of PD by assessing the fluid status, urea, creatinine, electrolyte. And PD dialysate fluid is always can cause hyperglycemia, so that may require insulin for correction that. And PD catheter may be removed during surgery, and hence facilities for emergency IJV hemodialysis should be available in case the graft does not work properly. All transplant, as usual, all strict asepsis must be followed. Now coming to emergency surgery, find out the severity of the corrective therapy, assess the efficacy of treatment and fluid status, assess the CVS from history and investigations. If already on hemodialysis, find out the time of last session, check potassium and ABG level, follow the same precautions. If time permits, optimize for heparin-free hemodialysis. Management of post-transplant patient for surgery, assess graft function by parameters of by blood parameters and physical examination. Absence of edema, breathlessness, anemia are all good signs. Immunosuppressive medication dosage should be known and continued if necessary if they are continuing on dope. And strict asepsis is again important if they are on immunosuppressive agent. AV fistula usually gets closed when the graft is functioning well. So you may just see the scar and the tortuous veins, but the fluid thrill, the blood thrill may not be there. So strict asepsis is there, especially when you plan a GA, because postoperative pneumonia is a very important complication in patients who are immunosuppression. And these are all some of the allied topics the examiners may ask you: physiology of urine formation, countercurrent exchange, countercurrent multiplication, structure and function of nephron, endocrine functions of the kidney, pharmacology of diuretics, role of kidney in maintaining homeostasis, preservation of renal function in aortic cross clamping, acute kidney injury, all these things. And this is the normal picture to show the various levels of the renal function, renal physiology, and how the urine formation takes place, and the 4 steps: ultrafiltration, selective reabsorption, secretion, excretion. So here this is written as a small formula. Excretion is filtration minus reabsorption plus secretion. So like a mathematical formula, you can remember that and try to write the answer on that. Now I have added a few slides on this, a little more elaborate thing on the management of heart beating brain dead donor, because this is a question which is repeatedly asked. I thought I will elaborate a little bit more on that. Now the brain death is often associated with marked physiological instability, and most of them are managed unless managed properly, they can lead to deterioration in organ function even before retrieval. So most of the patients are brought only from ICU because the head injury patients who are declared brain dead, they will be on ICU for at least a week or 10 days, and then finally the relatives have to give consent. So active management in ICU care before donation is important for maintaining the organ function. Generalized inflammatory and hormonal changes are associated with brain death. That is the basic fundamental pathophysiology. Generalized inflammatory and hormonal changes associated with brain death adversely affect donor organ function and propensity to rejection. That is the main reason. Pathophysiology of brainstem. Brain death is usually preceded by a variable period of increasing intracranial pressure. ICP is invariably raised in these patients. The changes due to raised ICP are superimposed on prior physiology, whatever comorbid diseases they have and what treatment they have undergone. All these things have a bearing on that. So common physiological derangements that you see in them, this is you can remember as a APHT. A for arrhythmias, P for pulmonary edema, H for hypothermia, hypotension, diabetes insipidus, and DIC or disseminated intravascular coagulation. So the mnemonic is a APHT. So hypothermia is very common, which damages and reduces the metabolism, causes vasodilatation, and hypotension, asplegia, hypovolemia, reduced coronary blood flow, myocardial dysfunction because of that. Diabetes insipidus is very common because of the pituitary damage, and DAC because of tissue factor release and coagulopathy. Arrhythmias because of catecholamine storm, myocardial damage and reduced coronary flow. And pulmonary edema because of volume diversion and capillary damage. So these are all the common physiological derangements. The goals in organ donation management are maintain physiology close to normal values, maintain body temperature, ensure adequate oxygenation, ensure optimal circulating volume, preserve cardiovascular stability, maintain adequate urine output. Rule of 100, which I have already shown, is systolic pressure more than 100, urine output more than 100 ml, PO2 100, hemoglobin, and the recent addition is the blood sugar 100% normal or 100 milligram per deciliter. Suggested cardiovascular goals for the active management of potential organ donors are to maintain a heart rate between 60 to 120, arterial pressure, systolic pressure more than 100, MAP more than 70, CVP between 6 and 10, urine output 0.5 to 3 ml per kg, electrolytes sodium 130 to 150, normal potassium, calcium, magnesium, phosphate, glucose between 4 to 8 millimoles, ABG normal pH, PaO2 normal more than 100, PCO2 35 to 45, SpO2 more than 95, and PCWP cardiac index SVR 6 to 10, 2.4, 800 to 1200. These are all very ideal values. If you are able to maintain this level, definitely the organ perfusion and the success rate will be better. Now, what are the physiological support you require in the operating theater for a donor? A multiple organ donation procedure involves midline laparotomy extending by sternotomy, even if thoracic organs are not retrieved. So even if they are not going to take the heart and lung, they make a sternotomy also. Maintaining stability during procedure allows unhurried removal of the organ without causing without undamaged condition. Spinal reflex movements are common, so you require a full neuromuscular block is required. And hypertension may be moderated with vasodilators, opioids, or volatile anesthetic agents. Volatile anesthetics may induce ischemic precondition in hepatic and cardiac surgery. So it may be advantageous to use volatile because the liver, especially if it is taken for as an organ for transplant, it may be providing the ischemic precondition. Methylprednisolone use is associated with increased organ retrieval and should be given as soon as possible. Thyroid hormone supplementation seems safe if overdosage is avoided. So you have to know the correct dosage and give it. Now coming to some of the reasons of why diabetic people come to develop nephropathy. The definition is persistent albuminuria from 3 to 6 months in at least 2 out of 3 consecutive urine collection with long-standing history of diabetes. This is one indication for the possibility of diabetic or a definition of diabetic nephropathy. The presence of diabetic retinopathy, hypertension, and decreased estimated GFR, they also are classified as a diabetic nephropathy. But remember, I'm not telling that they have gone on to the ESRD. They have started developing diabetic nephropathy, so they are potential candidates or to be termed as CKD patients who are likely to go for ESRD if not properly managed. So with the absence of clinical or laboratory evidences of other kidney or urinary system disease, then you have to make a suspicion. And diabetic nephropathy also has described in 5 stages. One is the first stage is the hyperfiltration stage where everything will be overworking. The kidney works to protect the body by overworking. Second stage is a silent stage. Third is incipient stage. Fourth is the overt nephropathy stage. And finally, it goes to ESRD. So these are all the stages of progression of diabetic nephropathy. So what are diabetic nephropathy patients dying from? They can die out of stroke. They can die out of myocardial infarction, heart failure, or for no reason they may have a sudden death also. Now, what is the histological change that you will see? See, in the same picture, all the 3 things are described. The normal on the left, you find there is a vascular endothelium, there is a basement membrane, there is a epithelium of the Bowman's capsule with the podocytes and all these things. Then there is a mesangial stalk infiltration. There is a cellular proliferation inside, and then finally, in the late stage, you have the diabetic nephropathy with all the damage to the endothelium. The basement membrane is damaged. The podocytes, all 3 structures are damaged. So that is how the whole thing changes. And this is again a stage how it is classified. 0 at increased risk with diabetes mellitus, high BP and a family history. Stage 1 to 2, kidney damage, microalbuminuria with a diabetes of duration 5 to 10 years, retinopathy, rising BP. So these 3 are the indicators for a potential kidney damage. And then 3 to 4, GFR starts decreasing, BP is still high, retinopathy is there, coronary vascular diseases also start occurring. And in stage 5, retinopathy, CVD, other diabetic complications, uremia, all these things happen. And what are the mechanisms? That genetic susceptibility, then there is a hemodynamic cause with raised intraglomerular pressure, biochemical because of all these factors, and growth factors are very much increased. That is one of the reasons I am going to show in a subsequent slide. And vasoactive substances like vascular endothelial growth factor, angiotensin, endothelin, all these things are also responsible for that. So this is a picture where it shows how this metabolic and hemodynamic factors affect the kidney, causing finally extracellular matrix accumulation and more proteinuria. And this is a biochemical thing where the polyol pathway, that is the whenever uncontrolled hyperglycemia is there, our body starts using other methods to utilize the glucose that is there, which is called the polyol pathway, which results in advanced glycation end products leading to oxidative stress and then leading on to finally, the one thing that you have to remember is there is an extracellular matrix protein for accumulation which develops or gets excreted. Hypertension in those with the disordered hypertension is that is people who develop hypertension after diabetes mellitus, they go for all these problems of lack of nocturnal dipping of blood pressure is considered as one of the important causes. You know, when everybody sleeps night, blood pressures are always low. If you do a ambulatory testing monitoring of blood pressure, after midnight to early morning, the blood pressure should be the lowest. That is called the nocturnal dipping. Whereas if the patient develops hypertension because of Ckd, this dipping does not happen, and this continuous PP even during sleep causes the endothelial damage which results in that. And there is an involvement of renin-angiotensin-aldosterone system also, which also acts through the angiotensin 2 receptors, increasing the nitric oxide, decreasing the tissue proliferation. These are all the actions of angiotensin 2. But if they are affected, then all these things go haywire and you have a vascular smooth muscle constriction and replacement of vascular smooth muscle with fibrotic cells. So angiotensin 2 acts through what is called nuclear factor Kb receptors, which result in the production of tumor growth factor beta 1, tumor necrosis factor alpha. All these inflammatory cytokines are produced, and aldosterone also is responsible for nephropathy, causing glomerulosclerosis, interstitial fibrosis, proteinuria, and then in the heart it causes ventricular hypertrophy, cardiac fibrosis, contractile dysfunction, and in the endothelium it causes dysfunction and inflammation and oxidative stress. Now there is another thing which is involved is a protein kinase C, which is also responsible for diabetic nephropathy causing hyperglycemia. So various mechanisms that are all doing that. And finally you find there is an increase in collagen and fibrosis and pro-inflammatory gene expression, which causes vascular occlusion and blood flow abnormalities also happen. So all these things lead to the, and transforming growth factor B also causes this problem. So the final change that happens is summarized here. Ckd, inflammation, Klotho gene. I'm going to talk about a little bit now. I don't know how many of you have heard about that. Decrease in Klotho gene, fibrotic FGF23 resistance, increase. This is a newer theory that has been propagated for diabetic nephropathy, and transformation of vascular smooth muscle cell into osteoblast, calcification of the vessels. And Klotho is a new protein that has been identified, which is responsible for control of hyperphosphatemia, angiotensin 2 blockade, vitamin D repletion. Now, this Klotho is a aging protein. It is otherwise also called an aging protein. When it is present in normal, if there is an acute insult, what happens is it is the common things that happen is apoptosis, necrosis, and detachment. But normal healing takes place and things come back to normal. But when this Klotho deficiency is there, it causes fibrotic repair and then goes on to lead to a chronic state of damage. So recovery and continued damage depend on the presence of adequate Klotho protein, which is the newer theory that has come in. And what are all the various structures that are affected in glomerular diabetic nephropathy is, it can be glomerulopathy, tubulopathy, vascular malformation or vascular insufficiency, and interstitial damage. So all the four structures are affected, and that is why diabetic nephropathy stands as number one reason for CKD. So there is a mesangial expansion resulting in glomerular hypertension, diffuse thickening of glomerular basement membrane, broadening of foot processes or loss of podocytes, reduced slit pore protein. So proteinuria happens because of that. Glomerulomegaly, adhesion to Bowman's capsule, neovascularization, diffuse nodular glomerulosclerosis, arterial hyalinosis. All these things happen. In the tubulopathy, tubuloepithelial cell hypertrophy happens, tubular basement membrane thickening, reduced tubular brush border, epithelial mesenchymal transition and accumulation of glycogen, expansion of interstitial space with infiltration of various cell types, myofibroblasts and macrophages, abnormal tubuloglomerular feedback mechanism, abnormal lysosomal procession, increased tubular salt reabsorption and impaired tubular acidification. So glomerulus is also affected and tubular function is also affected. And how do you assess the renal function? Urinary albumin creatinine ratio, it can be on a spot sample or a 24-hour urine protein. Then serum creatinine, electrolytes, GFR can be calculated by using Cograft or MDRD calculation, or you can do as measured by creatinine clearance. Renal ultrasound and Doppler. Serum creatinine level should be measured and creatinine clearance estimated annually in those patients with diabetes without albuminuria, and at least every 6 months in those with albuminuria. So if you detect microalbumin, you must start doing creatinine clearance at least once in 6 months. And the primary prevention, tight blood control of glucose with less than 7.5% HbA1c on insulin, less than 6.5, and for those not on insulin. And tight blood pressure control, some controversy about the absence of smoking and statin therapy. Targets for incipient and over diabetic nephropathy. Parameter, lower BP should be less than 130/80. Block renin-angiotensin-aldosterone by IACE or ARB to maximum tolerated level. Improve HbA1c to less than 6.5. Lower LDL cholesterol to less than 100. Anemia management is very important. You have to keep the hemoglobin between 11 and 12. Endothelial protection by aspirin, smoking cessation. These are all the things that can be done to prevent progression of diabetic nephropathy. Some newer therapies are inhibitors of these growth factors and vasopeptides, and pirfenidone, which is an antifibrotic agent. Some of the physicians have been using this in our COVID times also to prevent the fibrosis of the lung. And sulodexide, an agent postulated to restore glomerular change. Histone deacetylase inhibitors, raloxifene, and a selective estrogen receptor. These are all tried for preventing the progression of diabetic nephropathy. Now, coming to this newer thing which I learned only yesterday after going through some articles, the biological role of anti-aging protein Klotho is supposed to be one of the important newer things that have been included. Klotho is an anti-aging single-pass membrane protein predominantly produced with the shedding of the amino terminal extracellular domain into the systemic circulation. So it is produced in the kidney, and then by slight modification comes into the bloodstream, just like your erythropoietin and renin, which are all produced in the kidney and then coming to the systemic circulation. This is a newer thing that they have found out. Circulating levels of soluble Klotho decrease with age, and the Klotho gene is a very important with the increased risk of age-related disease. So when the Klotho level goes down, age-related diseases start happening. There are three forms of Klotho proteins. Membrane Klotho forms a complex with fibroblast growth factor receptors and functions as an obligatory co-receptor for HGF23, which is involved in aging. So all of us know that the fibroblasts are very important to keep our skin. The way we develop shrunken skin and stooping nature and the loss of musculoskeletal stability, all these things happen because of this particular problem. This is controlled via the phosphate and vitamin D metabolism. That is why nowadays there is more insistence on supplementation of vitamin D and keeping it in normal level. Then there is a secreted Klotho, which functions as a humoral factor with pleiotropic activities, including regulation of oxidative stress, growth factor signaling, ion hemostasis, and organ protection. Then there is an intracellular form of Klotho, suppresses inflammation, mediated cellular senescence, and mineral metabolism. So there are three varieties of that with individual functions, which ultimately, so it is like a kaya kalpam. If it is present adequately in your blood, you will never become old. You can always be young. So that is in the ancient Greek mythology, the Moirai are three fates, which is called Klotho, Lechis, and Atropos, were the daughters of Zeus and Themis, and they determined the duration of life. It was believed that Clotho spins the thread of life and Leches determines its length and Atropos cuts it. The Clotho gene is named after the Myra who spins the thread of life. So Clotho in human aging and diseases, polymorphisms of Clotho are correlated with lifespan, coronary artery disease, atherosclerosis, osteoporosis in humans. Clotho is also associated with severe calcinosis and stroke. So Clotho deficiency is involved in acute and chronic diseases, cancers, and salt-sensitive hypertension. The serum level of Clotho decreases with aging in humans. However, this is where the caveat comes. The biological function of Clotho and the way in which Clotho deficiency contributes to age-related diseases remains elusive. So this is in a still experimental or investigative stage, but there are evidences to show that it is going to be a very major factor in future. So this is the picture of the three fates described in the Greek mythology: Clotho, Leches, and Atropos. So Clotho is the spinner. You can see they are spinning the thread, and Leches is the allotter. So it allots the spin, and Atropos is the unturnable metaphor for death. It cuts the lifeline. So production, maintenance, cutting. So this gave me a small idea to think about this. See, Brahma is the creator, Vishnu is the preserver, Shiva is the destroyer. So we have equivalent mythological proof that these things are available in our literature also from time immemorial. And coming to the renal replacement therapy, sometimes it is asked to us no full question or a short note question in the theory paper. So I thought I will add a few things. So how dialysis, hemodialysis is done is blood is drawn out, removed from the body, pumped into the dialysate filter. And it is heparinized by adding heparin, and if necessary fluid also can be added, and there is a monitor to measure the inward flow. Then it goes into the dialyzer, and there is a dialysate fluid which is sent through one and then comes out through that. Why this is called as an artificial kidney? This dialysis filter is sometimes called as an artificial kidney. Can anyone answer that? Because the countercurrent mechanism which is there in the normal kidney is being done here. So if the blood goes in this direction, the dialysate fluid goes in the opposite direction. So the same mechanism what is happening in our kidney is being utilized here. So probably that is the reason why we call it as an artificial kidney. So after purification, the blood is pumped back into the patient after detecting that there is no air bubble or air trap, and the venous pressure is also monitored. So if there is any block or anything, these pressure monitors will give an alarm. And so this is the basic circuit diagram of your hemodialysis machine. Now this is the structure of a basic filter. Blood enters through that, and there are a lot of hollow fiber membranes here, and your dialysate fluid comes in this direction. So blood is flowing in this direction. Dialysate fluid will go in the opposite direction and come out after removal of all the waste products. And this fiber has got small tubes like this. Almost imagine a lot of straws fitted, the straw which we use for drinking cool drinks. They are all fitted like that, and the dialysis fluid goes in the one direction and the blood comes through these small tubes in the opposite direction. So you have a lot of surface area for absorption, and the difference between hemodialysis and hemofiltration. This is what I told you we can do intraoperatively, whereas hemodialysis you always require a dialysate fluid to remove the solutes and fluid, whereas in hemofiltration the blood is pushed into a filter with a semi-permeable membrane under pressure. And what happens, water and solutes, first the water, excess water will go, and it will take the solutes by convection into the hollow area, and the negative pressure will suck out the filtered fluid. So in hemofiltration, there is no use of dialysate fluid, whereas in hemodialysis, there is always a requirement of to use a dialysate fluid. So here there's another picture which shows this is the hemodialysis. The blood is flowing in this direction. The dialysate fluid is going in the opposite direction. In hemofiltration, blood is coming and it is whatever filtrate is taken out. There is no extra fluid that is going out. And if at all there is any need for any substitution solutions or added medications, you can do that either pre-dilution or post-dilution. But under pressure, it only filters. It's just like a filtering your coffee decoction. There is no additional fluid. Whereas here in hemodiafiltration, you combine both. You do the dialysis, you have to have an extra fluid coming. At the same time, you do it under a positive pressure. So it is called hemodiafiltration. And this is the picture of how it looks in a hemofiltration. No dialysate is there. That is the main difference between hemofiltration and in hemodialysis, there is a dialysate fluid flowing in the opposite direction. And the modalities of RRT can be classified into intermittent, continuous, and hybrid. In intermittent, it can be intermittent hemodialysis or isolated ultrafiltration. In continuous, there are several varieties, but most of them are veno-venous or arteriovenous. This is the common thing for all these things. So it can be continuous veno-venous hemofiltration or continuous arteriovenous hemofiltration or hemodiafiltration, which is veno-venous or arteriovenous. Again, hemodiafiltration, continuous hemodiafiltration, so combined only filtration, diafiltration, but mainly it is by either veno-venous or arteriovenous. And SCUF, slow continuous ultrafiltration, is also a newer thing, especially for patients in ICU with a renal disorder or lack of renal function. You do what is called the slow continuous ultrafiltration. In the hybrid variety, you have a sustained low efficiency daily dialysis. This is again for severe septic patients in ICU. You do this, and there is a modification where filtration also can be added. So this can be a short note question, SLEDD, sustained low efficiency daily dialysis. And how each one works is a continuous veno-venous hemofiltration. The therapy indicated for uremia, severe pH and electrolyte imbalance with or without fluid overload. Ultrafiltration is the method that is done. And the other one is the continuous veno-venous hemodialysis, which is continuous with the diffuse dialysis, and veno-venous hemodialysis with hemofiltration. And the vascular access can be either by the peripheral line. You can introduce the catheters through the brachial, brachiocephalic and go into the heart, which is not commonly done, but in case you are not good enough in or trained enough to do a central venous catheterization, they can be pushed through the peripheral vein. And central line, it can be through the subclavian or through the internal jugular. And if you keep it permanently, this is called a perm cath, where you introduce it either through the jugular or through the subclavian, and there is a small cuff which prevents it from coming out. So if you want to do a long term, they say perm cath can dialyze the patient. You can use it for dialysis for up to 6 months without any problem. Whereas IJV, you can hardly use it for less than a month, because the chances of vascular complications or infection or thrombosis are very high, whereas perm cath can be used up to 6 months, which can be introduced by one of the central vessels. So this is also called the tunneled catheter insertion. And after your insertion, you take a picture, X-ray, it will be like this. And the type of access that you have for hemodialysis, you can use the central, or you can use an AV fistula, or you can use a Gore-Tex graft inserted between an artery and vein. Especially with people with poor vascular, natural vascular access, you would use a graft, and peritoneal dialysis. So these are all the various access that you use. And the indications for dialysis, it can be either metabolic acidosis, and easy to remember is the vowels A, E, I, O, U. A for acidosis, E for electrolytes, hyperkalemia and hypermagnesemia, I for ingestion of certain alcohol or drug intoxication, O for refractory fluid overload, U for uremia, pericarditis, neuropathy, and decline in mental status. So these are all for acute renal replacement. But what we do with a fistula formation and support, it's called the renal support rather than renal replacement therapy. Okay, that is done even before any complication sets. So if you institute renal replacement with a fistula at an elective time, it can be called as a renal support rather than complete renal replacement. So for a successful kidney transplant, you require a team approach. There is a nephrologist who prepares the patient, decides the immunosuppression, and then takes care of the post-transplant scenario. Urologist who does the harvesting, anastomosis, and bleeding control. Anesthesiologist who maintains pressure, hydration, acid-base balance, electrolytes, and renal protection. And overall staff are required for infection control, nursing care, and support. And if you do all these things, you are supposed to get a spurting urine on the table with a good vascular anastomosis and maintaining and preserving the melee interior of the patient. Okay. So that is the end of the story. Okay.
Sir, what about heparin-free dialysis?
Heparin-free dialysis is done because nowadays when you want to do an urgent dialysis and take up the patient for surgery, instead of administering parenteral heparin, there is a heparin coated tubings are available, which prevent, after all, what you want is not to form a thrombus inside the circuits, isn't it? So there are coated, heparin coated tubings that are available, which are specially used for this purpose, where you don't administer any systemic anticoagulation. You just like that draw the blood and pump it through that, it doesn't clot inside. But it can be done only for a short duration.
Yes. Yes. Sir, a higher pressure has to be maintained, sir, for during transplant. So
when the clamp release is done, you have to maintain a higher pressure.
So that patient we have what BP higher side you will use? How much it will have? It has
whatever be the initial blood pressure of the patient, if you are able to maintain that, that is good enough. For example, if it doesn't have auto regulation. It initially until about 3 to 4 months, it doesn't develop any auto regulation. The transplanted kidney remains pressure dependent only. So all the time you have to maintain first criteria is adequate pressure, main arterial pressure to pump the blood. Second is adequate fluid. So if you lack in fluid, then also urine output will be low. And if the first criteria, if there is a hypotension immediately after clamp release, then the kidney will never become turgid at all. It will remain very soft. So you have to, if your blood pressure is good, slightly on the higher side, you can see the kidney becoming solid rock-like, very turgid and fully filled with blood. And the color also will be very pink.
They say it's ideally should be around 130 to 160, no, sir? 160.
No, it depends on, that's what I told. No, I have done a patient who had a BP of 230 by 140 consistently during the preparation period with, during dialysis on the table, and his BP did not come down by any treatment. He was on 3 drugs. He was on beta blocker, he was on calcium channel blocker, he was on arcamin, which is an alpha-2 agonist in those days. In spite of it, the BP was 220, 140, but he did not have any features of severe hypertension because like headache or visual disturbance or any chest pain. Nothing was there. So I thought it is the natural BP for that man and took up that patient, and it immediately went on very well, and 10 days after transplant only his BP became 130/80.
So then
So
Holter
such,
monitor will be useful in such cases to monitor the 24 hours maximum and the minimum BP range.
no, whatever you do, that the blood pressure, it has been persistently high, whether you do Holter or not, what are you going to achieve?
There's a
It's
maximum BP and the minimum BP for that particular patient. It will be helpful.
Yeah, that is if you are going to take up that patient who has complications because of BP, like LVH or other problem, then it is the ideal. What is described by Chris Roberts is to play the BP between the maximum and the minimum. That can be achieved by Holter. But in a CKD patient who has a very high BP, I don't think it is of any. Holter is not a really required one.
Yes.
A patient, suppose a patient of CKD has come for a lower limb surgery, and so what do you suggest? Should we go for spinal or should we go for GA?
If he has
So
got
if we
no
go for
coagulopathy issues, if he has been on CKD, that's why I told you two categories of patients are there in CKD. One is not on renal replacement therapy with a GFR of 30 to 60 with a normal urine output. If such patients are there, you can go for a regional technique for any infra-umbilical procedures like hernia, piles, hydrocele, lower limb
so will
operations.
vasodilatation will cause any renal perfusion compromise in such
No.
cases?
That's what, if you are able to maintain the level below thoracic level, up to lumbar level. Okay. What is required is only if it's a block is required only to up to lumbar level, you will not have a very drastic fall in BP. And even if there is a fall in BP, you can always manage it with a vasopressor like ephedrine or phenylephrine instead of rushing fluid like an normal patient. So if you do that, the renal pressure, see in such patients who are not on renal replacement therapy, our idea is to maintain whatever renal perfusion is happening and urine output is happening should be continued. We should not precipitate an acute renal shutdown in that patient by a persistent hypotension. Say after giving spinal, the BP drops to 80/50 and you allow it to be there for about 45 minutes to 1 hour, whatever existing renal function may also collapse and patient may require urgent dialysis and all these problems can happen. But if you are able to immediately correct that BP with a vasopressor and allow the block to be very low, then the renal function will continue to happen and he will have the normal same whatever output he has been having and he can go through the surgery without problem.
Phenylephrine is safe for these patients.
Phenylephrine is safe to give to increase the BP. Any other questions?
So any specific precaution for patient with post-renal transplant, sir?
Specific precaution is if first find out whether they are on immunosuppression or not, because some patients who come with a very close related donor, like father giving to son or mother giving to daughter or sister giving to brother, what happens is after a few years or say a couple of years, they can afford to stop the immunosuppression because their matching is so good, tissue matching is good. Rejection chances are very, very low. So they can afford to stop the immunosuppression. Then all you have to do is assess the renal function, their urea creatinine level, their overall well-being, whether they are not going in for any anemia or anything. And if their urine output is normal, whether their BP is under control, whether the cardiovascular status is okay, then treat them like a normal patient. On the contrary, if the patient is still continuing immunosuppressive agents because it is an unrelated donor or the matching has been little not up to what is called the full house match, then you have to take all the precautions for preventing any infection. Especially if you give GA, your sterility should be very good. Your laryngoscope should be properly sterilized, and your ET tube should not touch anywhere when you do a intubation. And your circuit should be fresh. You should not use the same breathing circuits which you have used for 2-3 cases. And fresh soda lime should be there, which are all likely to spread an infection into the lung. Postoperative pneumonia is a very, very important complication that can happen in the presence of. We may be practicing all hand washing and other sterilization by painting the patient and all that. But lung pneumonia is a very important complication which can be caused by us by not taking care of these small things. So that is a very important thing, and the proper antibiotic cover should be given. So immunosuppression patients, asepsis is the most important thing. And of course, if you keep the volume and pressure properly, the graft function also will be well preserved. So after a few years of transplant, you will be like a normal patient only without any problems. So except for asepsis, you don't have to worry much about that.
Thank you, sir.
Welcome.
Thank you, sir. Thank you so much.
Okay.
There's no question in the chat box, sir. So if there are no further questions from students, can we sign off today's meeting, sir?
Yeah, sure. Thank you.
Okay, sir. Next week, we are requesting you to have a class on liver disease, sir, DCLD.
Okay, right.
And I requested Dr. Selvamani from Professor Selvamani from Balaji Hospital to give one student to present a theory answer for hepatitis B virus and anesthesia. And our Dr. Rajesh Kumar from RH Perambur, he will present a case posted for hepatectomy.
Okay.
Okay, sir. Thank you, sir. Thank you, sir.
Thank you.
Good night. Good night, students.
Good night. Okay.